Hello, can anybody hear me? Hello, can anybody hear me? Please just let me know if you can hear me.
Yes, we can hear you. Yes, we can.
Okay.
Good evening, everyone. My name is Joanne Kuyet Solomon, and today we know that we are going to have a seminar, and it's going to be about the fallacy about malaria and typhoid. The link was just sent to the group, so we'll give others like 5 minutes so they can join. Our speaker is already here, Dr. Dennis Yaga. You're highly welcome, sir. So please, let's give the rest like 5 minutes to join so that we can continue. You're all welcome once again. Hello, everyone. You're welcome once again to this amazing seminar. We were supposed to start by 8 p.m., but some community members are still joining. So let's give them like 2 more minutes and see. You're welcome.
Oh, thank you.
Hello, everyone. You're welcome once again to this health seminar organized by I Need a Doctor platform, which is a community that tries to connect different people, different patients to health professionals. And we all know that malaria is a serious problem to a lot of countries, especially in developing countries like Nigeria. And as much as possible, we want to ensure that people get sensitized about the misconceptions about malaria and typhoid. And so we decided to come up with this seminar to help us to learn and unlearn about malaria, and typhoid. We have an amazing speaker in our midst. That's Dr. Dennis Daniel Yaga. He's a resident doctor in hematology at the University of Abuja Teaching Hospital.
Good evening.
So you're all welcome. I would like you to keep your fingers crossed because you are going to be getting a lot of information about typhoid and malaria. And also, I would like you to listen to this seminar with an open mind. I know we all think that we know a lot about malaria, but I want you to listen with an open mind and learn from everything our speaker will be saying today. So, Dr. Dennis, are you available? Dr. Dennis,
Can you
can
hear
you
me?
hear me?
Yes, I
Yes.
am. Good evening, everyone.
Good evening. You are welcome, sir.
Thank you.
Okay, we are glad to have you here, and I'd like us to start. We have 15 minutes behind schedule, so I'd like us to start so that others can join as we continue the class.
Okay, all right, that's fine then. I think our time is already fast spent. We're 15 minutes behind schedule, so we could just go ahead and start. Okay, good evening, everyone. My name is Dennis. I'm guessing most people here know me already, but if you don't, yes, my name is Dennis. I attended Kaduna State University. I'm currently a resident doctor with Department of Hematology at University of Abuja Teaching Hospital. So this evening we'll just be briefly going through. Sorry, let me just go ahead and share my screen. Sorry, the host, please, can you enable me to share my screen? I see the feature is disabled.
All right, sir. Let me do that immediately.
Okay. Yeah, so while she does that, I will just be having a brief discussion on what malaria is, what typhoid fever is, and the general misconceptions out there on what these two disease entities are, if they always occur together, if they are mutually exclusive of each other, or when one is present, the other must also be present. I'm guessing we also have doctors in this meeting, so we both have our experiences where you have patients come in and you tell them they don't have, they almost argue with you and telling you, oh, I must have this. If I have this, I must have that. So this evening we'll basically just go through a brief overview of what that is. Okay, so can I share my screen now?
Sir, can you try to share it now?
Yes, I have. It's still disabled.
Please try it again, sir.
Okay. All right. So can everybody see my screen?
Yes, we can.
Okay. Okay, yeah. So as I was saying, we're going to be having a chat this evening. It's not a lecture, it's not I know it's a semi-formal setting, but let's just be relaxed. It's going to be a chat, and as much as we can, I would want this to be very interactive. So if you have a piece of paper, please jot down questions, jot down comments, and I would want to get a feedback from you. That's the only thing that really guarantees or really assures me that we follow during the lecture. So please let's be attentive and then follow. Let's also be prepared to make inputs at the end of so I titled this chat Malaria and Typhoid Fever, the Nigerian pseudo Siamese twins. If you're a student of history, I'm sure you must have read or heard about the Siamese twins that were born conjoined. So I also want to look at malaria and typhoid in that sense, even though in the real sense of it, they are not conjoined. But Nigerians generally believe that these two disease entities are born together, are always together. Whenever one is present, the other must also be present. You know, it's almost like it's a sin for you to have malaria and not have typhoid. Whenever the moment you have fever and you're in the hospital, they tell you, oh, you have malaria, typhoid, and then you go on taking a barrage of drugs for these two disease entities. So briefly, we'll just be going through. I put a first slide here, which is a disclaimer. First, I would want us to approach this chat. I'm not calling it a lecture anyway, so just to add some informality to it. So I would want us to approach this chat from a place of one, it's an advocacy. Two, it's for information. Please, this is not a replacement for sick while you're sick. It is not a substitute for consulting a doctor or consulting a health facility whenever you're sick. Whatever I'm going to be saying in this lecture, whatever drugs I'm going to be mentioning, please, they are not for you to go on self-medicating. And they are also not for you to self-diagnose yourself of these ailments. Best advice would always be whenever you're sick, you should seek professional help from the right quarters. And I would also want to say that I know we have a lot of health personnel in our midst. So this presentation has also been watered down to a point where almost everybody following, irrespective of your profession, whether you're in the health sector or not, you'll be able to understand and follow whatever I'm going to say. So for those who are in the health profession, do not be disappointed. This has been watered down a lot and I tried as much as possible to replace a lot of medical jargons with everyday lingua, so we are able to communicate. No, it's basically just information distribution. All right, so I'll be discussing using this outline. Would get to find out what malaria itself is, the mode of transmission, what are those signs and symptoms that when you have, it suggests that you have malaria. And then how is this malaria diagnosed? When you get to the hospital, what is your doctor going to tell you? And eventually the complications of this disease, the treatment, and also prevention. Now, I would want us all to pay attention, rapt attention, particularly to the prevention, because as global best practice now, medicine is moving towards preventive medicine rather than curative medicine. So what you can prevent is always better to prevent than to, treat when you eventually have the ailment. So same with typhoid fever. We're going to discuss the causes, what typhoid fever is, the causes, the transmission, the mode of transmission, the signs and symptoms, diagnosis, treatment, and the prevention as well. All right, and then while I speak, I'll also be mentioning some of the general population have about these entities. Right. So malaria is a compound word. It is not an English word. It is a compound word that was gotten from two Italian words. basically mal and area. So mal means bad and area means air. So that literally translates to bad air. It was initially thought that malaria was caused by an exposure to air which was considered not pure, air which was considered bad. So they named it bad air. Now, over the years, research was able to prove that malaria was actually caused by um, a parasite, a protozoa known as Plasmodium. Now, Plasmodium has a lot of species, but the most important and the most clinically relevant are about five, and the most common to African countries rather, to we that is the Plasmodium falciparum. Now, it's the commonest cause of malaria in our environment. It's the commonest cause of malaria worldwide, even. It's also the most dangerous of all the five, and it is spread by the female Anopheles mosquito. Now, you always hear our parents tell us, oh, try not to get bitten by mosquitoes. Oh, put on long clothing. So close the windows so the mosquitoes don't come in. Right. So they may not have known why they say that, but it's actually been correlated that when you get mosquito bites, you get malaria. So yeah, female Anopheles mosquito carries this falciparum virus. Not the virus, sorry, protozoa. Carries the Plasmodium falciparum parasite, and whenever it bites an individual, it introduces a form of this parasite into the blood. He undergoes a life cycle. I didn't want to bore us with the life cycle, so we don't lose some people along the line or along the way. So I'm just going to basically say, once it bites, introduces a particular form of the Plasmodium into the blood, the injected form now develops over time, changes names as it goes, and then becomes a full-blown protozoa that causes the infection. Now, this particular parasite can also be transmissible by blood transfusion, organ transplant, and it's also been known to cause congenital malaria infection. So it can also be transmitted via the placenta. Now, so what are the signs and symptoms of malaria? How do I feel? What do I feel to make me know that I have malaria? So the commonest one is fever. Everybody knows. Um, I know if I'm going to sample opinions about what fever, um, opinion on what fever is, but basically it's a rise in body temperature. So your body feels hot, but you're cold, you're shivering, but when you touch your body is hot. You have headache, you're going to have body pains, and then in more moderate or severe forms, you also have enlarged organs. So you have organomegaly and you have splenomegaly as well. Nausea, vomiting, abdominal pain, and diarrhea. Those are also some of the symptoms that come with malaria. Now, oftentimes you hear people say, my malaria has a way it presents. So someone tells you, no, my malaria doesn't come with fever, it comes with headache. No, my malaria comes with body pains and not fever. So these symptoms are not, it's are not, so it's not an all or none rule. You must not have all the symptoms I've listed here for you to know you have malaria. In fact, for some, it could just be fever. For some, it could just be headache. And for some, you could just be having generalized body pain, joint pains, and then nausea, vomiting. So it presents in different forms. However, fever and headache are the most common forms that it presents with. And yeah, so, okay, so for the fever, the pattern is usually paroxysmal. By paroxysmal, it is repetitive. It comes at the same time every day. So you wake up in the morning, you're fine, the symptoms are better, you feel stronger, you can eat, your appetite is better. But then once it's 3 o'clock, 4 o'clock, those symptoms start creeping in again. By 5, your body is already burning up. You're hot, you're cold. By 6, 7, it gets worse. So yeah, it's usually follows this pattern that it gets better during the day, and then once it's evening time, it gets worse. When you're having this kind of fever, it should be a pointer to you that this could likely be malaria. All right, so I just included some infographics here. Some of us are better visual learners than auditory learners, so you've not been fever comes with headache, comes with muscle aches, comes with excessive sweating, nausea, vomiting, diarrhea, and then those are the milder forms. It could get worse. It could present in more severe forms where you have cerebral malaria, where you have different other severe forms of malaria. Okay, so you're having these symptoms, you're having headache, you're having fever, you're having chills and rigor, vomiting, and you go to the hospital. How is the doctor seeing you going to come to a conclusion that you have malaria? Now, what your doctor does is he is going to take a clinical history. A clinical history would include asking you questions about your symptoms, how you're feeling when your symptoms started, if your symptoms get better at a certain time of the day compared to other times of the day. He's going to also ask you a lot of questions about your lifestyle, your diet, and some of the things you do. He will ask about where you live, your exposure to the environment, and all of that. If whether or not you use a mosquito net or you don't, whether or not you flit often or you don't. So he's going to ask you some of these questions. These questions are all parts of information gathering to be able to make an informed clinical decision, or rather an informed clinical test of you having a malaria, which he's going to further confirm by carrying out a test. You would also do a physical examination, which will involve taking your temperature, taking your vital signs, other vital signs, including your pulse rate, BP, respiratory rate, oxygen saturation, and all of that. Now, the most important here being your temperature. He's going to take your temperature, and that would be the first pointer to you possibly having the malaria fever. Because one, you're going to be feverish. The temperature is going to be way above the normal range. Um, he's going to also examine other systems of your body. Remember, we mentioned that in the more moderate or severe forms of malaria, you have splenomegaly and hepatomegaly. So he's going to examine to see if you have some of these things. By I said I've avoided using a lot of medical jargon. So by splenomegaly and hepatomegaly, it just means an enlarged liver and an enlarged spleen. So that usually happens, or most times, sometimes rather, it happens with malaria infection. Right. So after doing a physical examination, he's going to then order for laboratory investigations. Now, the most common, the most available laboratory investigation that is done in most places is the rapid diagnostic test kits, RDTs. They are usually preferred in most places because they give very quick results. So you just put a drop of blood on it, you put the buffer, and then you wait for it to react. That usually takes about 3, 4, 5 minutes at most, and you already have your result. But these form of tests are not foolproof. By being not foolproof, I mean that they have a tendency of missing when you have malaria. They would diagnose you as being negative when in the real sense you actually have it. They also have a limitation of not being able to quantify the amount of parasitemia you're having. By parasitemia, I mean the amount of parasite in your blood. It cannot quantify, so that way you don't know if it's simple malaria you're having or it's you have heavy parasitemia, you have heavy infestation of plasmodium parasite in your blood. So the gold standard for the diagnosis of malaria is actually by doing a blood film, a blood microscopy where you do a thick film and a thin film, and then you visualize it using a microscope. So I added a picture of what that would look like here. You could see what he has on that black stage is a slide, and then he's looking at the microscope trying to visualize the slide. Now, as a hematologist, that's what we do most times, that our eyes even go bad. So you're always looking at the microscope. You look at one, the shape of the cells, the sizes of the cells, and then you also look at inclusions of the cells. By inclusions, I mean things that are within the cells that are usually not supposed to be there. So that's where you see malaria parasites. So from the blood film, you'll be able to tell if there's heavy parasitemia, if there's moderate parasitemia, or it's just mild parasitemia. Now, if you have mild parasitemia, these rapid diagnostic test kits, the RDT kits, are not going to be able to pick it up. So it's always better, and that's why blood microscopy, the thick and the thin film are the gold standard for diagnosis, because no matter how low the parasitemia is, no matter how little the malaria parasite is in your blood, your whoever is looking at it on the slide is going to pick it up. Now, more advanced tests could be the polymerase chain reaction test, which are the PCR tests usually done in molecular laboratories. But most times you don't require the use of some of these specialized diagnostic modalities to be able to diagnose malaria. Now, these are usually used in temperate regions of the world where malaria is not endemic. So usually they have malaria as a differential to every form of pyrexia. By pyrexia, I mean fever. So they usually carry out this PCR test to be able to definitively tell if a patient has malaria or not. But in our climate where we are in the tropical region, malaria is endemic to us, our parasitemia is usually high. So the RGT kit and the thick and thin blood films will be able to reveal when we have malaria. All right, so you've been diagnosed of having malaria. They've done the thick and the thin film, and your doctor tells you that, oh, you have malaria. I know most of us we must have heard 1 plus, 2 plus. Now, what those pluses mean? It just tells you the amount of parasitemia. Like I explained earlier, parasitemia is just how much of malaria parasite you have in your blood. So when we say heavy parasitemia, it means you have a lot of those malaria parasites in your blood. When we say mild to moderate amount, significant enough to cause an illness, but it is not significant to cause severe malaria anyway. So those pluses just help to highlight that. So 1 plus could be considered mild, 2 pluses could be considered moderate, and then 3 pluses could be considered severe. Now, if you're having simple, uncomplicated malaria, the doctor will most likely recommend an artemisinin combination-based therapy to the ACTs. Now, over the years, the ACTs have been discovered to be the gold standard in the treatment rather of malaria, replacing the all-famous chloroquine that was used in time past. Now, the issue is the tendency to elicit anaphylactic reactions, allergic reactions, because it causes a lot of degranulation of mast cells releasing histamine. Okay, so that's me speaking a lot of medical jargons now, and I said I was going to avoid that. Now, the chloroquine was just associated with itching. I know some of us must have taken chloroquine and we had body itching, we had some flare on our skin. So that's an allergic reaction to that, and that led to the discovery of artemisinin. It was first discovered in Asia, in China, precisely, and then modified to produce some of the drugs that are used in combination now for the treatment of malaria. So your doctor will recommend an ACT for you. And then most times they will add an antipyretic for you. So probably they'll put in paracetamol there or add an NSAID for you. What that does is helps bring down your body temperature while allowing the ACT to deal with the malaria parasite. So first, you want to do symptomatic management. So what the antipyretic or the NSAID does is to bring down your body temperature, relieve any pain you're having in the immediate term, and also relieve any headache you're having in the immediate term while allowing the actual drug that deals with the parasite, which is the ACT, to sufficiently deal with the parasite. Now, another drug that is used for treatment is quinine. Quinine is another anti-malaria that is used. Most times it's reserved for severe malaria and also for pregnant women who have malaria. So our ACTs are not safe in pregnancy, especially in the first trimester of pregnancy. So doctors try as much as possible to avoid the use of the ACTs in the by first trimester, I mean first 3 months of pregnancy. Try as much as possible to avoid the use of ACTs in the first trimester pregnancy. They've been found to be teratogenic. That is, they've been found to cause malformations in babies.
Hello, Dr. Yaga. We can't hear you any longer. Hello?
Okay, sorry, I had a problem with my network briefly there. Can you hear me?
Yes, welcome back. Welcome.
Okay,
We can
all
hear you.
right. Okay, so I was talking about Fansida. Fansida is a combination drug. It's a combination of sulfadoxine and pyrimethamine. It's usually used in pregnancy as a preventive, as a way of preventing malaria in pregnancy rather than treating malaria in pregnancy. So it's given as it's the drug that is actually used for IPT. IPT is intermittent preventive therapy for malaria. So they give Fansida to prevent malaria in pregnancy. So other drugs that are used to prevent malaria in a certain population of patients, we have propanil that is used for sickle cell patients. So what they take as paludrin, used to prevent malaria in them. It's also used for people who live in temperate regions who are traveling to the tropical regions. So people who are traveling from areas where malaria is not endemic and are coming into a malaria-infested area like ours, they would need to take some of these chemoprophylaxis to come in. So it prevents them from having malaria. Now, these treatments I just outlined, those are the treatments for simple, uncomplicated malaria. Now, your doctor is going to evaluate you and is going to diagnose you appropriately, and is going to also risk stratify you and then put you into the correct category for either being an uncomplicated malaria or being complicated malaria. That is what is going to inform the kind of treatment, the drug he is going to prescribe for you. So if your malaria is simple and uncomplicated, oftentimes ACT does the job. But if it's complicated, that's when the need for parenteral therapy arises. So your doctor might prescribe a course of an injection for you. This injection could be given either IV or IM. By IM, I mean you could be given either on your buttocks or your arm or wherever there's a huge muscle mass. They could give you there. And alternatively, they could also set an IV line for you. That is a drip line. Then administer this through those lines. So the choice, making the choice for this drug is also for some of these medications is determined by the severity of your malaria infection. So some of these drugs include your artemether, your emal, which is Atita, and then artesunate, which is usually reserved for very severe forms of malaria. Now for the complications, I just listed a few here. There are more. The commonest ones being anemia, because, okay, so I said I avoided talking about the life cycle because I didn't want to bore some of our participants who are not medical personnel. Now, what the malaria parasite does to the blood cell is it goes into the blood cell and causes it to rupture. So by rupturing the blood cell prematurely, it makes it initiates a cascade of a reaction whereby your blood cells keep rupturing prematurely. And if your blood cells keep rupturing that way, it's going to get to a point where your blood cells, especially the red blood cell count, is going to go low because you are now destroying the red cell more than you're producing. So that's just a plain way of explaining it. So yes, it could cause anemia, it could cause cerebral malaria. Like I said, that's the most severe form most times, causing unconsciousness, causing convulsions, causing coma, especially in children that are under 5 and pregnant women. It could cause organ enlargement. I mentioned hepatomegaly and splenomegaly earlier. It could also lead to kidney failure, and then it could also lead to shock. So this to me is the most important part of this lecture, the prevention of malaria, because it is always better we prevent having malaria than having to treat it itself. So for the sake of convenience, I've stratified the prevention strategies for malaria into 3 and at 3 levels. So one, the first level at which we need to prevent malaria is one, since we already know what causes malaria, parasite, the Plasmodium falciparum, and we know the vector that carries this parasite, the first way of preventing us from having this is by one, ensuring that you do not have this parasite or the vector in your environment. So that is the first level of prevention. So you try as much as possible to reduce the population of the vector and the parasite in your environment. How do we do that? These parasites, the Plasmodium falciparum that is carried by the female Anopheles mosquito, they reproduce in stagnant waters. So they like very moist environment. They like stagnant waters. They like very dark corners. So very dark corners, very moist areas, dark bushes, tall bushes rather, and stagnant waters. So to be able to prevent them from reproducing in these areas, one, you need to ensure you do not have stagnant waters around your environment. So it's either you sweep them away or you cover any holes you have in your environment. Two, you need to clear all the bushy areas in your environment because they also like tall bushes because it's obviously dark in those areas. So they also reproduce there. You need to clear all the dark bushes in your areas. Now, Now, if you have a water body, say a lake or a pond or any water body, any stagnant water body in your area, and it is not something you can do away with, another way you can prevent this vector or the parasite from reproducing in these waters is by adding a barrier to the surface of the water. Now, the barrier to the surface of the water could be in the form of oil. You could add oil into the water so it forms a coating on the surface of the water. That prevents these parasites from reproducing in these areas. Now, you could also do routine environmental sanitation, which, like I mentioned earlier, by clearing any tall bushes you have around your house, by also ensuring proper lighting of the inside and the outside of your house. So both surrounding have proper lights around your area. So the mosquito itself is a nocturnal insect. So it operates in the dark. It's why most times they walk in the night. So it's a nocturnal insect. It operates best at night. So you want to lit up your environment to help reduce these mosquitoes from coming into your abode. Then two, if the first level of prevention fails, that is, you're not able to prevent or reduce the population of this vector or the parasite in your environment. So at the second level of the prevention now, you now have these parasites in your environment. And trust me, we live in a tropical region. We in Nigeria, we're in a malaria endemic region. So it is almost impossible to not have mosquitoes in your environment. It is almost impossible. So the most efficient level of prevention for us happens at this second level because we already now have this parasite in our environment. But the aim of this prevention is to avoid contact as humans with this parasite or the vector for the parasite. So you want to prevent you yourself or your loved ones from having mosquito bites as much as you can. You want to because you have them in your environment, so you need to carry out things that will stop these mosquitoes from biting you and introducing the malaria parasite into your. So some of these methods could include using an insecticide treated net, which has been found to be the most effective means of preventing mosquito bites by not just having it, but correctly using it, because it's one thing to have it, it's another thing to use it, and it's also another thing entirely to use it correctly. So one, you need to get a mosquito net. Two, you need to ensure consistent usage of it. And then three, you need to ensure proper usage of it. Now, I'm just going to take my time a little bit on this level because I feel it's the one that pertains to us mostly, and it's also the most important part of this chat we're having. So for a mosquito net, for an insecticide-treated mosquito net, you say you just buy one from the market. You know, it already has the insecticide injected into it. You bring it home. How do you go about using it? So one, you need to air dry your mosquito net. By air drying, I mean you need to hang it in the open, not under the sun. You need to hang it in the open where there's shade, but then air can get to it. So you need to hang it outside, air dry it for at least 12 to 24 hours. After air drying it for 12 to 24 hours, the aim for this is to allow some of the insecticides that have been injected into this mosquito net to escape into the environment, because that also helps to reduce the dose of this insecticide you would be exposed to once you start using it. So after doing that for at least 12 to 24 hours, you take it inside the house and then you get ropes and you get pegs to peg it on the wall um, at a position that covers your bed completely. Now, it will also be pegged at a height that you'll be able to fold it tuck it around your bed, or if your mattress is not on a bed frame, then it should be at a height where you'll be able to fold it under your mattress. So you don't just hang the mosquito net around your bed, but you make sure it is tucked around the bed if there's a bed frame, But if there's no bed frame, you fold it under your mattress. Now, once you've done that, you need to also prevent your opening and closing of the mosquito net as you leave your bed and as you come back in. Because remember, I said our aim is that you want to prevent these mosquitoes from getting to you because you already have them in your environment. So the aim at that level is to prevent them from getting to you. So if you have your mosquito net hung and you keep opening it frequently and then not minding how you open and close, it's going to give these vectors, which are the mosquitoes, leeway to get into your net. And once they get in, it's always difficult for them to go out. And then the aim of actually hanging the net itself would have been defeated. So one, you want to prevent these mosquitoes from having access. Two, if you have any tears in your net, you want to fix them as soon as possible because these tears will encourage these mosquitoes from coming in, and it also breaches the barrier the net creates between you and the outside environment. So that's one way. The other one would be the consistent and proper usage of insecticides in the house. So I know some people are claustrophobic. By being claustrophobic, I mean people who don't do well in enclosed areas. So such people may not feel comfortable using mosquito nets. So such people would prefer to do what we call fleeting. So they use insecticide. The problem with that is most times we do not use it correctly. That is one. Two, we also do not use it in the proper environment. And then three, after using it, we do not maintain the right conditions. So if you're using insecticide and not the mosquito net, you would need to one, spray it in your room at least 2 hours before your bedtime. At least 2 hours before bedtime. That is to allow the the toxic dosage or the toxic dose of this insecticide you've sprayed in your room to reduce a bit and to be able to reduce to a level that will not be injurious to you, but then still be at a level that it will be able to kill these mosquitoes in the room. So one, you need to spray it, I said, at least 2 hours before bedtime. That is one. Two, you need to also limit how you open and close your doors, how you open and close your windows after you sprayed your insecticide. Three, you also need to ensure that you use the right type of insecticide. There are a lot of brands in the market. There are a lot of products in the market that these days you hardly can vouch for any product. You spray it, it's as if the first 5 minutes the mosquitoes are quiet. After 1 hour, you hear them flying, singing in your ears, and then you see them flying around. So ensure that you use a quality, you buy a quality and also spray it correctly, maintaining the right conditions in the room. That is ensuring your windows are closed and your doors are locked, ensuring that you don't open and close the door frequently to allow more mosquitoes to get into the room. Another way of also preventing these mosquitoes from getting to you would be by the use of mosquito repellents. So there are a lot of products out there where people apply them on their skin, people apply them on their body. I particularly do not find this method effective because you literally cannot bath yourself with mosquito repellent. So you can only apply them to areas that are exposed. But then different areas of your body are exposed at different times. So you may not particularly, you may not be able to cover your whole body with this mosquito repellent. So I do not find this method effective. Even though some people might prefer using this method, I do not personally do not find it effective. Another way of preventing these mosquitoes from getting to you would be by using long clothing. So you use very long clothing that covers your body. You use stockings, you use long sleeves, especially towards evenings. Like I mentioned earlier, the mosquito is a nocturnal insect, so it operates from evening to night. So once it's evening, you know that you have stockings on and you have your long sleeves on. That could also prevent the mosquitoes from getting to you. Now, getting to the last stage of the prevention. Now, you've done if the two levels of prevention have failed. So one, you failed at preventing or reducing the population of the parasite and the vector in your environment. And then two, you've also failed at preventing them from coming in contact with you. That is preventing them from biting you. So we are at the third level of prevention where it's beating you and malaria parasite into you. So the level of the aim of prevention at this stage is to prevent complications. That is to prevent you from having the malaria itself and then developing its complications. So you want to ensure early diagnosis of the condition and then prompt initiation of the treatment for malaria. That way you know that you're nipping it in the bud. You're not allowing it time to grow into something bigger and more difficult to treat. So I've gone through the three levels of the prevention. Please, I would want you to note questions on this prevention because, like I said, I consider it the most important aspect and part of this chat we're having. So one, you want to reduce the population of these parasites and the vectors in your environment. If that fails, it means you now have them in your environment. Then you want to prevent them from biting you. So you want to prevent mosquito bites. You want to prevent parasite and the vectors from coming in contact with you. So I've also outlined some of the preventive measures you use at that stage. Then if the two level measures of prevention fail, you then go to the third where you ensure early diagnosis of your condition and then prompt initiation of treatment. So that's for malaria. I'm going to quickly just talk about typhoid fever because I see our time is fast spent. Okay, so malaria is one part of the Siamese twins. Like I said, pseudo Siamese twins. So it's a false the perception is a false perception of these two being conjoined twins. But like I said, they are actually, in the real sense, they are actually not conjoined twins. So we've discussed one of the twin, and I'm going to be talking about the second twin now. So typhoid fever, which is also called enteric fever, is caused by a bacterium known as Salmonella. Now, Salmonella has different species. Remember also that we said malaria is caused by Plasmodium. Plasmodium has different species, but the most important in our environment is the Plasmodium falciparum. Now, for typhoid fever, it also has different species, but the one most important for the causation of typhoid fever is the Salmonella typhi. It also has other subtypes, which are the Salmonella paratyphi A, B, and C. Those are less relevant to the causation of typhoid fever. Humans are the only host for typhoid fever. However, this bacterium is carried in different forms. So it can be carried in urine, it can be carried in feces of infected individuals. So humans can carry it as cases. Now, cases here mean people who have the infection. That is, people who have an ongoing typhoid infection. So those are called cases of typhoid fever, or they can be carriers of typhoid fever. Now, by carriers here, we mean the bacterium in their blood, but are not symptomatic yet. So they have it in their blood, they have the ability to shed the bacterium in their stool and in their urine, but they are not symptomatic for typhoid fever yet. So those can be considered to be carriers. I'm sure most of us must have heard the story of Typhoid Mary. Typhoid Mary was a nanny in a house. She owned a restaurant rather, and it was discovered that whoever ate at this restaurant eventually developed typhoid fever. And an investigation into it eventually discovered that that Typhoid Mary was a carrier for for typhoid fever. It meant that she had the organism, which is Salmonella typhi, in her blood, but she herself was not symptomatic for typhoid fever. She had the ability to pass it on to other people. So the typhoid fever can exist in the carrier state. The primary source of infection is usually feces and the urine of cases. By cases, remember I also said cases are people who have the bacteria in their blood and already have symptoms. So they have an active typhoid infection. Then secondary infection can be from contaminated sources, so from contaminated food, from contaminated water, contaminated fingers. And then the vector for this most times is our common housefly. So the housefly is the vector that has been implicated in the spread of typhoid fever. They are responsible for carrying this parasite, this bacteria from contaminated source, which is either from the feces, from urine, or from contaminated waters into our food, into the water that we drink, and that's how we contact the organism and eventually develop typhoid fever. The incubation period is around 10 to 14 days. That is the time it takes for when you take in the bacteria and when you start having symptoms for malaria. It's around 10 to 14 days. Sometimes extend up to 21 days, depending on how heavy or depending on the amount of bacteria you have in your blood. Now, the mode of transmission, like I said, is fecal-oral. By fecal-oral, I mean from stool to the mouth, or uro-oral, that's from your urine to the mouth. Now, fecal-oral, it means that the bacteria has been shed in the stool of an individual who is either a case or a carrier. An individual who is either a case or a carrier has passed the bacteria in his stool. The housefly then carries bacteria from the stool into either our food or into our water. And then this water is either used to make food, and we then eat the food and we get the bacteria, or we even drink this water directly and we get this bacteria from it. So oftentimes you hear people advocating about having a wholesome source of drinking water to prevent typhoid fever. It's usually that you have a source of water that you're so sure it has not been perched on by flies repeatedly. That's one. A source of water that you know has not been contaminated by feces from any source. That's two. A form of water that you also know has undergone some form of treatment to kill some of these bacteria that must have been deposited in the water before it was collected. Now, the spread of the organism that causes typhoid fever, which is the Salmonella typhi, encouraged by open defecation. So open to air defecation that could do, you know, so I know this is commoner in the villages where there are no proper WCs, there are no, even pit latrines, there are no proper pit latrines. Even for pit latrines, most times you see flies flying out of pit latrines and then, perching on food, perching on water, and perching on several places. So that's one way this bacteria can be spread. Also from contamination of drinking water supply. So if your source of drinking water gets contaminated, it could also be a source of this infection. Now from vegetables and fruits, oftentimes we go to the market, we buy vegetables, we buy fruits, and we know that some of these fruits and these vegetables are gotten from irrigation farming. Now, irrigation farming is an out-of-season way of farming where farmers use water from either rivers to water their crops and then grow these things, most times during dry season. Now, the source of the water could be contaminated, and then this contaminated water is then used to water these crops. These vegetables are harvested with this bacteria on them. If they are not properly washed and are not properly cooked, we go ahead to eat them. That's another way of contacting this bacteria that causes typhoid fever. And also low personal hygiene. So if you have a bad culture of hand washing, you put your hands everywhere and the next thing you're already using your hand to eat without washing your hand. You go to work, you shake lots of people at work, you collect money from the conductor, you collect money from the okada. You go back home, you don't wash your hands. The next thing you see a bar, you're already using your hand to eat. You see rice, you're already using your hand to eat. You see meat, you're using your unwashed hand to eat. This is a common practice that will encourage the spread of Salmonella typhi. Now, I just put a flow chart here to help us understand everything I've been saying. So if you've not followed everything I've said about the mode of transmission, this flow chart here should help you understand it better. So it starts from an infected individual, which could either be a case or a carrier, spreading this bacteria in their stool or in their urine. Now, this stool gets into water, gets carried by flies, and then it gets on the fingers or into the soil, even from the irrigation that I just spoke about. And then this water is used to cook food, either not properly cooked or even raw food, like our fruits that we eat them raw. Or you bring your unwashed hands with this bacteria on it, and you're already eating. So that's how you introduce this bacteria into your system, and you get typhoid fever. At this point, I would want to pay attention to this mode of transmission of typhoid fever. You could see that there is a sharp contrast between how we get malaria and how we get typhoid fever. Could also see that we have entirely two different organisms that cause malaria and typhoid fever. And we also see that the method where we get these infections are also two different methods. So I would want us to be noticing these subtle differences, even though I'm going to be pointing out these differences at the end of the lecture, but just be noticing these differences in the mode of transmission, in the organism that causes it, and how we are able to get these disease-causing entities from the environment. Okay, so for the signs and symptoms of typhoid fever, I know most of us must have experienced it, even though what most people experience, it's malaria instead of typhoid fever. So in the first week, you usually have what is known as a step-ladder form of fever. Now, by step-ladder, it means that today fever might be mild, tomorrow it gets worse, day after tomorrow it's worse. Like it never gets better. Now, also notice the difference with the fever I described for malaria. For malaria, I said it's paroxysmal, meaning it's repetitive. So it occurs almost at the same time every day without worsening symptoms. So it does not get more severe on the second, third, or fourth day. So the fever comes in the evening, extends to the night. By morning, you're fine. The next day, the next evening, it comes back again. By the next morning, you're fine. The next evening, it comes back again. That will be in a repetitive fashion without getting worse. But the fever that happens in typhoid fever is in a step ladder form where it starts with mild low-grade fever and then continues to increase as the day goes. So on the first day, it could be mild fever. On the second day, it progresses to moderate fever. On the third day, you're already burning up, having an above 40-degree temperature. So it keeps increasing that way. It also comes with headache, a vague abdominal pain, and constipation as well. You could also come with muscle pain and then generalized body weakness. So from the second week, that is when you must have had the secondary bacteremia. I also do not want to talk about the life cycle and the natural history of the um, typhoid fever, because I know that would bore a lot of people that are not medically inclined. So I would save us the details. But then by the second week, we expect what we call the secondary bacteremia to have occurred, and organ organ infiltration must have also occurred at that stage. So that's the point where you could have liver enlargement, you could have spleen enlargement, and then you could also have some skin rashes known as the rose spots and diarrhea as well. So by the third week, at the stage where most people present to the hospital. because, for the first, second week, it's still, a bit mild, and, the symptoms are just getting worse by the day, getting worse by the day. And by the third week, the patient is already presenting with apathy, there's toxemia, there's disorientation, some even coming with coma, some come with explosive watery stool, and if left untreated at that stage, it could become complicated to the point of having intestinal perforation and bleeding. So when I see people in the consultation room and they come with the notion that they have typhoid fever, I tell them that if you have what is actually known and called typhoid fever, you will not be able to even walk here yourself to tell me you have typhoid fever. Because symptoms for typhoid fever itself could, sorry, just a minute. Okay. So the symptoms for typhoid fever could um, actually keep you bedridden. Severity itself is usually more than what we term as typhoid fever. So more often than not, the fever we have, the headache, generalized body weakness, the muscle, it's mostly from malaria and not typhoid fever. All right, so this is a pictorial representation of symptoms, signs and symptoms you could have. Fever, headache, pain in the abdomen, loss of appetite, muscle ache, generalized body weakness, and all of that. So how is the diagnosis for typhoid fever made? Just like in malaria, your doctor is going to take a history from you. He's going to ask you questions about the pattern of the fever. He's going to ask you questions about your dietary habits and your sanitary habits. And then he's going to do a physical examination on you also. And then he's going to order for some tests, some investigations. Now, the widely used test or investigation in most places you go to is the Widal test. The Widal test is an incorrect or is an inaccurate method of diagnosing typhoid fever. I repeat that again. It is not a correct method of diagnosing typhoid fever. If you go to a hospital and you're being investigated for typhoid fever and your doctor says he's going to order for a Widal test for you, please kindly decline and insist for a culture. A culture is the gold standard for diagnosing typhoid fever. Now, what the Widal test does is it measures antibodies in the body. Now, for people who are science students, you know the basic principle of antigens eliciting the production of antibodies by the immune system. So when you have this Salmonella typhi in your blood, it elicits production of antibodies against this organism in your blood. And what the Widal test does is to measure these antibodies. But it is not just Salmonella typhi that is able to produce these antibodies that are measured in the blood. That is one. Then also what Widal test fails to account for is if you're having an active typhoid infection or you've had it in the past. So if you've had typhoid infection in the past, your body is going to produce antibodies for it. So whenever you're tested for the antibodies, you're going to have these typhoid antibodies in your blood. So what the Weller test does is it just measures the antibodies. It does not tell if it is an active ongoing infection or it is a latent infection or it is an infection that has happened in the past that has led to the production of these antibodies. And because of cross-reactivity in the production of antibodies, it is also not specific for Salmonella typhi, as other bacteria are also able to elicit the production of these antibodies. So the Widal test, it is not a good method for the diagnosis of typhoid fever. Best method for the diagnosis of typhoid fever is a culture. Now, the sample that will be used depends on the time of presentation. So if you present within 1 week of exposure to the Salmonella typhi bacteria, a blood culture will be the best method for diagnosing typhoid fever. If you're presenting within the 3rd week, a stool culture will be the best method for diagnosing typhoid fever. And if it's in the 4th week, a urine culture will be the best method for diagnosing typhoid fever. So I just added a picture on the right of what the culture test looks like. This bottle here is the bottle that you'll be given to produce your stool, and the lab scientists will take the stool and then make a culture of it. They would incubate it for about 48 to 72 hours and watch for the growth. Now, what the culture yields is usually the growth of the bacteria that causes the infection. So that is a more definitive way of telling if you have it or you don't have it, and if it's an active infection or a latent infection. So for treatment, antibiotics are the mainstay for the treatment of typhoid fever. Usually we use oral fluoroquinolones. It's a class of antibiotics. We also use chloramphenicol, amoxicillin, and ampicillin for the treatment of typhoid fever. It's also important to state here that choice of antibiotic is also dependent on culture and sensitivity patterns. So if you do not have a culture result yet, you might start empirical therapy with the culture and sensitivity pattern of that geographical area. So take, for example, Nigeria. Our culture and sensitivity pattern for Salmonella typhi in the recent past was ciprofloxacin. So ciprofloxacin was the commonest effective antibiotic against Salmonella typhi. But because of how that antibiotic has been abused over the years, antibiotic resistance has developed and has made Salmonella typhi to become resistant to this particular antibiotic in our environment. And that is gradually pushing us towards the use of third generation cephalosporins. So that's where the use of drugs like ceftriaxone comes in, the use of second generation cephalosporins too, like your cefuroxime, that's where that also comes in. And then it also depends on if the person is having an active infection or the person is in a carrier state. Remember, I said we would either have them as cases or as carriers. So as cases, meaning there's an active ongoing infection, you use these antibiotics depending on the sensitivity pattern. That's after you must have cultured either your blood, the stool, or the urine. The choice of the antibiotic is based on this. But please, this choice of the antibiotic, I just included it in passing because it is not for you to decide. The doctor seeing you is going to request for this culture results, and he is going to decide which antibiotic best treats your condition, and he is going to prescribe it to you. This lecture, like I mentioned in the beginning, is not a replacement for seeking professional medical help whenever you're having these symptoms, and it's not a replacement, or it's not also it's not an endorsement for self-medication and then self-diagnosis and self-prescription of medications. So if the patient you're seeing is one who is a chronic carrier and not having an active infection, like the typhoid Mary I mentioned earlier, you usually require a prolonged therapy. So usually about 4 weeks of antibiotic therapy. And for some, they also recommend gallbladder removal, even though that comes with its attendant complications. So usually we stick to prolonged antibiotic therapy, which is about 4 weeks. Now, some other treatment you could offer to these patients is supportive therapy. So you want to do symptomatic management before antibiotics will take effect and address the root cause of the infection. So like we did the malaria where we handled the headache, the body pains, the fever with antipyretics and analgesics. We do same in typhoid fever. So after giving your antibiotics, you also do a symptomatic treatment where you take care of pain, fever. If the patient is dehydrated, you rehydrate the patient and also provide adequate nutrition. Some of the complications, I've mentioned them along the line as I was discussing earlier. Toxemia, the patient comes in very sick. Some might even come in shock. Some come in with intestinal perforation and bleeding. Some will even come in coma, convulsing. Some come with different degrees of presentation. So it's really that serious. Typhoid fever is really that serious. You could see a patient coming in with coma. You could see a patient coming in with seizures. You could see a patient coming in with altered sensorium, altered level of consciousness, already coming with intestinal obstruction, intestinal perforation, and different forms of presentation of the disease. For sickle cell patients, particularly, they also have the risk of coming with bone infection because of secondary bacteremia that spreads in the blood and then gets to the bone and just stays there and forms a local bone infection. So it gives them osteomyelitis. So for the prevention of typhoid fever, if you followed what the discussion up to this level, you would understand that hygiene is the mainstay for the prevention of typhoid fever. You've seen that it is caused by eating contaminated food, drinking contaminated water, not having proper sanitary practices, not having proper hygienic practices, eating vegetables that are not properly washed, eating food that is not properly cooked, taking fruits that are not properly washed. These are all the things that will expose you to having typhoid fever infection. So one, sanitation, it cannot be overemphasized. Protection and purification of your drinking water sources. If you can, please drink clean water. Drink from a source that you're so sure of. Drink from a source that you're sure is not contaminated. Promotion of food hygiene. Mind where you eat your food from. Buying street food, eating from restaurants, you're not so sure of how they make their food, or you're not so sure of their source of water for making their food. Buying food from roadside vendors, you should be very careful because you do not know how some of these food items, some of these meals are made, and if they're produced in the most sanitary conditions. And also, there's a vaccination against typhoid fever. I know it is not common in our environment. It is not part of the MPI schedule. It is not part of the things we do routinely in our environment. But you could walk into any health facility and request for it. So it can be given on request. So you request for it, it can be provided to you. It's mostly recommended for those living in typhoid fever endemic areas like our area here, like our environment in Nigeria. It's also recommended for at-risk population, school children, hospital staff, household members of someone who has had typhoid fever in the past, and also food handlers, like our typhoid Mary, that was a food handler with a career of typhoid fever and kept spreading it. So vaccination is also needed in food handlers. Also included a pictorial representation of some of the prevention methods of preventing typhoid fever for some of us who are more visual learners than auditory learners. Okay, so this is just a brief information about the vaccine. So our time is fast spent, and I'm just wrapping up right now. If you didn't get any, if everything I've said didn't make sense to you, if everything I've discussed so far was boring and not so interesting to you, please, I would want you to take these points home, and this should be your takeaway from today's lecture. That malaria and typhoid are caused by two different organisms. Malaria is caused by a protozoa known as Plasmodium, while typhoid fever is caused by a bacteria known as Salmonella typhi. These are two entities, two separate entities, mutually exclusive of each other. They must not happen together. They most often do not happen together. In very rare cases, they happen together, but they must not, and in most cases, do not happen together. That is, malaria and typhoid co-infection are very, very rare. So if you go to the hospital and you're like, oh, doctor, I have malaria, treat me for typhoid too. If you are having symptoms that are pointing that you have malaria, say you have headache, generalized body pain, you have generalized body weakness, you have fever and all of that, let your doctor be the one to decide the kind of test you will do. to tell you what you have. Do not insist that, oh, doctor, I have typhoid. In fact, it gets back to a point where people own some of these illnesses. They'll tell you, my typhoid is back again. So they own some of these illnesses, and they even try to argue with you. Tell them, oh, you cannot even have typhoid, because if you had what is actually known as typhoid, you wouldn't even be able to walk into my office yourself. They will argue and tell you, no, that is what I usually have. My typhoid is back. I actually have typhoid. So please know that malaria and typhoid are caused by two separate organisms. They are gotten from two separate sources. In fact, if you're even insisting that you have typhoid, what you're telling us is that you're dirty. You must have consumed feces of a person that has typhoid fever. That is what you're actually insisting and saying. A double diagnosis of typhoid and malaria is rare and often incorrect. It is rare and often incorrect. If you go to a hospital, they tell you they are treating you for malaria, typhoid. Please ask them, what test have you done to make this diagnosis? What test have you carried out to be able to tell that this is what I have? Have they been able to do a malaria parasite test for you? Did they do a blood film for you? Did they do a blood culture, a stool culture, or a urine culture for you to tell that you have typhoid fever? These are some of the questions as educated patients we should begin to ask from our caregivers, from our healthcare workers. We should begin to ask our doctors, not being confrontational, but then asking to know what is being done for you. So you go to a doctor's consultation room and he tells you, oh, I'm treating you for malaria and typhoid. And then you just put a question to him, please, what tests have you done to be able to tell this is what I have? Because I attended a lecture and I was told that malaria and typhoid co-infection is very rare. So how possible is it that I have both at the same time? You could have typhoid separately, you could have malaria separately, but having them as a co-infection is rare, and the diagnosis of that is often incorrect. So typhoid infection has a characteristic presentation, and your clinician should be the one to see you, take a history, do a physical examination, and then carry out investigations to make a correct diagnosis for typhoid. Best test for the diagnosis of typhoid, like I mentioned earlier, is a culture. The sample for the culture will be determined by the time of presentation. The whiteout test is an unreliable form of investigation for diagnosing typhoid fever. Personal and environmental hygiene is what can be used to prevent typhoid fever. Vaccination facilities are also available currently, though currently not on the NPI schedule, but they can be provided to you on request. So we've come to the end of our lecture. Basically, what we've been able to do is to differentiate malaria fever from typhoid fever. To be able to, we've also been able to state the organisms that cause both infection, and we've discovered that they are distinctly different from each other, mutually exclusive. And we've also established that these are two infections that do not and must not occur together. One happens without the other. So because you have malaria, it's not cast on stone that you must have typhoid occurring together. In fact, most times they do not even occur together. And we've also discussed the method of diagnosis for these two separate disease conditions, and the most accurate method of diagnosis for these separate conditions. So I'm going to stop here, and thank you for your rapt attention. I would now hand you back to the moderator who would open the floor for questions and comments. Thank you.
Thank you so much, Dr. Dennis Yaga. We are so thankful to you for taking your time to expatiate and give us detailed explanation about the misconceptions about typhoid and malaria. We are so thankful to you, and I would like us to drop our questions. If you have any question, please, you can drop the question in the chat box so that we can quickly ask before the meeting. Drop it at the chat box. Or let me allow us to unmute ourselves in case you want to say it out. If you have a question, please ask. If not, we'll come to the end of this health seminar.
Okay. So
okay, I can see one hand up.
Yeah,
Please go ahead with your question.
I think you should let people unmute and ask questions. Some might not be so comfortable typing, so just allow people unmute.
Yes, I've allowed everyone to unmute his or her own mic. I can see one hand on. Didi, please, can you go ahead with your question?
Okay,
she
I
has
kept my
dropped her
own.
hand. Okay, it's all right. So we'd like to thank you. Okay, go ahead, please.
I said I dropped my question in the comment section.
Oh, okay. Okay, Dr. Dennis, she's asking a question. She said, is it safe to say that malaria and typhoid twin illness is a business scheme by most health practitioners, and typhoid twin illness is a business scheme by most health practitioners? That's her question. Hello, Dr. Dennis, can you hear me? Hello, Dr. Dennis.
Okay, so I think you should
Dr. Dennis, can you hear me?
Yes, I've just been able to unmute. I wasn't able to unmute earlier. So please, I think you should just disable the
Okay.
the
All
central, right. The central lock, so people can just easily unmute at will. So yes, question about if the pseudo-Siamese twin infection is a business by health practitioners. Now that's
But did you get her question?
I did.
Okay.
Yes, so it's not, I cannot give you a straightforward answer because it's a yes and no is it answer. Now it's
I think
yes.
she's the only one with a question here. Everyone.
Can you hear me?
Yes, we can hear you.
Okay, yes. So I was saying that the answer to the question would be yes and no at the same time. Now, it depends on the places you go to. There are a lot of places where one, they just do without test to satisfy the urging of the patient. That's one. Two, they make the diagnosis, the double diagnosis of malaria and typhoid at the full infection to you know how you go to a river and you cast a wide net hoping to catch something at least. So you're not throwing just a hook and a line in one particular place to catch one fish. You're throwing a very wide net with the hope of, that's bad, you will catch something. So that's the point here. Most places we go to, which I would call mushrooms private hospital, for want of a better word, would usually use this double diagnosis so they could give you an antibiotic and an anti-malaria at the same time, hoping that it could be one of these things. So if it's typhoid fever, antibiotic takes care of it. If it's malaria, anti-malaria takes care of it. But that in the real sense is not proper practice. Proper practice would be carrying out the appropriate investigation and correctly diagnosing what the problem is, then making a prescription for what the patient has. Now, for if it is a money-making scheme or not, I would not want to dabble into that, but most people do that out of one, satisfying the urging of the patient because patients insist they have typhoid, so let's go ahead and do that for them. That's one. Two, for the without test, yes, they do that for the without test because they want patients, they still make money from it, even though it's a useless investigation anyway. So yes, I would say I would answer that as a yes and a no. Yes being that it's done from a place of trying to satisfy the patient and from a place of also making personal gain. And no, it's not a money-making venture because two, it could also be from a place of ignorance from the kind of health practitioners you're meeting. So it depends on the caliber of health practitioner you're meeting, the expertise they have, and the understanding of the concepts of these two illnesses they have.
Okay, thank you very much, Dr. Dennis, for that response. I think she's comfortable with your response. Okay. I don't know if anyone has any other question, but I can't see any. So with that, I can say that we have come to the end of today's health seminar. We would like to thank you once again, Dr. Dennis, for giving us your time, for taking our time to make so much research and teach us what we need to know about the fallacy about malaria and typhoid. Fortunately, on April 25th, it will be World Malaria Day, and so this session came timely. Thank you so much, Dr. Dennis. We are so grateful to you. And for the rest of our participants, we also like to thank you for joining this session. Without you, the session wouldn't have held, and so we are so grateful to you. Thank you so much, everyone. With that, we have come to the end of today's health seminar, and we hope to do more of this. I don't know if Dr. Dennis has anything to say to us before we leave.
Okay, nothing more, but just to say, okay, so I'm going to be sharing the slides on the INAD platform. It's also
Okay.
to help us read it more and then digest it more. And to beyond just this lecture where we've learned some of these things, it should be that the next time you're seeing a health practitioner, the next time you're in the hospital, you insist that some of these things be done correctly. So like the person that mentioned that asked if it's a money-making venture by hospitals. Now, some of these hospitals capitalize on the ignorance of patients to carry out some of these things. So if you know that you're actually supposed to do a stool culture to be able to diagnose typhoid fever, the next time you're in a hospital, you're going to insist that that is done for you before you're commenced on treatment. Even though sometimes treatment is done empirically before the results of cohorts come out. But you would be able to insist that this investigation is done for you. And when a doctor makes this double diagnosis for you, you'll be able to ask some questions as to why he has made that diagnosis for you. So beyond this lecture, it's that we are applying this knowledge to our practical everyday lives. And also the preventive measures is to also help us stay away from some of these illnesses and then needing this care and this help for the treatment of some of these illnesses. I want to also thank the INAD platform for providing this opportunity to be able to share this to people. I know it's a common topic, and it's it's a topic of interest to a lot of people out there. So thank you to INAD for providing the platform for this to be.
Thank you so much, Dr. Dennis. We hope to see more of you here, and I hope that everybody has learned one or two things. I personally have learned a lot. And so thank you once again. With that, we've come to the end of today's session. Please have a good night's rest, everyone. Thank you so much. All right, bye.